This is a 64-year-old patient who presented 18 months ago with dysphagia. An upper endoscopy at the time revealed a tight tumor stricture caused by squamous cell carcinoma in the mid-esophagus. This PET scan shows the original tumor associated with bulky mediastinal adenopathy and also supraclavicular lymph nodes. This was staged as locally advanced disease, and the patient received chemotherapy and radiation after gastrostomy tube placement. This CT scan obtained 14 months ago, or 4 months after initial presentation, shows a tight stricture in the mid-esophagus, but some contrast still goes through, as you can see here. The large area 7 lymph node appears unchanged. Unfortunately, the patient's ability to swallow continued to deteriorate to the point where he was unable to handle his own saliva. The patient was referred to us for a second opinion. This barium study shows complete obstruction of the esophagus. Even after 20 minutes, there was no emptying. A subsequent peroral endoscopy showed a dilated upper esophagus which is completely obstructed at the level of the mid-esophagus. Instead of tumor, a smooth epithelialized surface is seen. We then examined the esophagus from below using the gastrostomy tube stoma for entry into the stomach. The situation from below was similar. No tumor, but a blind end with a smooth surface was encountered. Based on the initial endoscopic evaluation, the patient was set up for a repeat endoscopy with 2 endoscopists using 2 endoscopes simultaneously, one coming from above, the other one through the gastrostomy tube stoma from below. The initial plan was to trans-illuminate from above and advance a 19-gauge US FNA needle from below, guided by the trans-illumination. After successful advancement through the fibrous obstruction into the upper esophagus, a .035 guide wire would be passed through the FNA needle, received with a snare in the upper esophagus, and then pulled out of the patient's mouth to allow further interventions. This sequence of fluoroscopy images shows both endoscopes in place. Unfortunately, trans-illumination was not possible, and the puncture had to be performed solely under fluoroscopic control. Anatomically, the marked dilation of the upper esophagus compared to a more funnel-like aspect of the lower esophagus was helpful in constraining the approach from below in such a fashion that a successful puncture through several centimeters of fibrous tissue appeared feasible. Nevertheless, considerable force was required to accomplish this. Here the FNA needle is seen, and finally a 6, 7, 8 mm biliary balloon was used to dilate the stricture. After access had been established by means of a guide wire, there was still not enough room to use dilation catheters, and a Halbrechts needle knife was employed to enlarge the tract by carefully cutting in a radial direction. A controlled radial esophageal balloon could not be advanced through the tract, but a biliary balloon dilation catheter, which has a smaller catheter tip which measures only 4.5 French, went through. During a second dilation session, a few days later, the tract was further dilated to 10 mm. The follow-up barium esophagogram shows a good functional result, and the patient commented how relieved he was that he could swallow again and did not have to spit into a cup all the time. He tried a liquid diet and tolerated it well. To consolidate the results, a 10 cm long ultraflex esophageal stent was placed. This case illustrates how complete esophageal obstruction can be managed by endoscopic interventions, but also More importantly, it reminds us that prophylactic placement of removable plastic stents should be considered in patients with advanced tumor strictures prior to chemotherapy and radiation. The authors would like to thank Jody Sanchez, Lisa Prater, and Colin MacDonald from the Boston Scientific Corporation for their invaluable help.